Okay, here they are. We have plenty of people on this podcast, but that's how we do it on Healthcare Unfiltered. And I appreciate everyone who actually took time to come on the show. So let's just do a quick, brief intro. I think everybody who is listening or watching this, they know we are going to debate the KETO-CTA study. So, Nick, we start with you.
All right. My name is Nick. My background is a PhD in human metabolism from Oxford. I'm currently a medical student at Harvard, at least for 3 more weeks. We have graduation coming up, so that'll be exciting. But I'll pass it off to my friend Dave.
I'm Dave Feldman, the crazy engineer who got obsessed with lipids and ultimately got us into this big mess. Adrian.
I'm Adrian. I am also a clinician. I did my PhD in physiology, which is where I met Nick. And I am a clinician with a strong inclination towards numbers. I have experience and I collaborate mostly with statistical analysis. And that's it.
Thank you, Adrian. And John?
I am a cardiac electrophysiologist. I practice in private practice, and I have got interested in critical appraisal of studies and trials over the last 10 years. I write for Medscape. I'm an editor of the Sensible Medicine podcast and host of the This Week in Cardiology podcast.
And I admit, I'll say this, that John, you're probably one of the most thoughtful cardiologists that I have encountered. And I'll go on the record that if I am sick, I'll be calling you. So because I know that you will look at things critically and you won't just rush to give me stuff. Okay, so Dave, you started all of this mess. So can you tell us how this started like in 60 seconds? And then Adrian's going to tell us about the study. And then I want to start to take John's takes on the actual study. Just recall that last week we just taped the episode, so everybody knows about the study by now. But go ahead, Dave.
Sure. We've identified metabolically healthy people, lean mass hyperresponders and near lean mass hyperresponders who have gotten CT angiograms at Lundquist out of UCLA for day 0, and then a year later, 365 days roughly later, they would get a second scan. This was for 100 participants, and that way we would have longitudinal data to see how much their extremely high levels of LDL cholesterol might impact their plaque development, absent other cardiovascular disease risk factors, which was another piece of the eligibility criteria.
And what got you interested in this? Like, what made you decide to pursue this?
It happening to me that I decided to get off of carbohydrates to deal with diabetes, but then my cholesterol shot through the roof, and that was the one thing that was sticking out of concern. And so I wanted to understand how much risk it might actually be.
And then that's how you met Nick, because Nick was having the same issue?
Yes, except arguably he's very competitive. So his LDL is much higher than mine. And understandably, just like me, motivated a lot out of fear to try to study this phenomenon.
Nick, just really quick, like how high are we talking about? You know, you went on the keto diet. What are the numbers we're talking about?
My last LDL a couple of weeks ago was a 574.
574. And that's the highest you've had, or you had higher than that?
That was actually the highest. My most recent one's been the highest. My HDL is around 120, 125. My trigs on last measure were 34. So very classical and extreme version of the lean mass hyperresponder phenotype.
Right. So Adrian, what does this 100 participants longitudinal study that was published already show?
Well, first of all, or now I like to summarize it into 4 main messages. First of all, that this population, despite having unusually stringent inclusion criteria, is an heterogeneous population. Not everybody behaved the same. Some people had lots of plaque progression or more plaque progression than what you observe in healthy people, and some people had low plaque progression or low plaque changes. So it's not a homogeneous group. That's the main message. Despite their inclusion criteria are strict ones, and they seem overall healthy, as any clinician knows. Everybody's healthy until you start asking for tests, right? So if even when it's a well-characterized population, there's heterogeneity. The second finding is that in this population, the observed plaque changes are not explained by their apolipoprotein B, or the changes in apolipoprotein B, or their exposure to apolipoprotein B, or LDL-C in some analysis. And the third message that I would emphasize is that the best predictor to see or to predict who is who in this heterogeneity, who is a fast progressor, who isn't a fast progressor, the best metrics or way to predict that was with baseline plaque metrics. So having more plaque in the beginning predicts having more plaque and more plaque changes in the end. The usual lipid markers of LDL-C or ApoB were not predictive of these changes. And yeah, I think that's in a nutshell the main findings of that paper.
Before I let John provide some counterpoints, I have to. So I'm not a cardiologist, and I'm not really an expert in none of these things. I'm like a citizen. When I see these numbers, it's hard for me to say. I'm like, well, take a statin and just call it a day. Like, what's the big deal? Is it the fear that the statins have adverse events? Like, is there an underlying thing that made you concerned? Because the LDL is high, people take statin and move on. Or what, you know what I mean?
I mean, I can feel that from the position of even just a patient, which is, I think a lot of lean mass hyperresponders feel they're a distinct phenotype, that they understand the etiology of their high LDL is different than anything that's come before. So because of that, if they're a population that hasn't been studied, the medications that are frontline medications also haven't been used on this population. And I don't think it's controversial to say statins have side effects. The degree to which they do in any given individual, say at low doses, or the long-term consequences vary. I'm not trying to like fearmonger around them, but without more data on lean mass hyperresponders as a population, I think some people are just uncomfortable pulling the trigger and signing up for lifelong therapy without further information. Now, in terms of the way, I won't even speak for my colleagues, but the way I communicate it when asked, first of all, I never give medical advice, but when I talk about my own story, I'm very clear, despite spending a lot of time studying this, my decision right now not to be medicated is not one that I grasp tightly. It's where I stand now, but I won't say I have confidence in my decision. Like, I know the stakes.
Right.
And so I think this just remains to be an open question, but really more to the point of what you're raising. Let's be very clear. This wasn't like a randomized controlled trial where we're preventing patients from accessing pharmacotherapy to lower their LDL. This is self-selected for people who are already refusing and were offered pharmacotherapy as an option. So it just comes down to, we have the opportunity, a natural experiment, if you will, to study the natural progression of this phenotype with high LDL, because the patients are self-selecting not to take medications, not because we coerce them anyway.
Got it. John, you've read the trial, you've heard from the authors and the motive and so on. As a seasoned and practicing cardiologist, maybe initial thoughts as we delve deep into it.
Well, the initial thoughts would be that I'm not an imager. I don't claim expertise in CTA imaging, but I'll tell you that in heart disease, the endpoint is events, MI, CV death, and stroke, atherosclerotic events. And, the CTA images are surrogate measures for, we think that plaque progression, plaque imaging will be a reasonable surrogate, but we don't know. The real answer and endpoint is cardiac events. And a study like this, it can't really get to that. So my first point is that if one proposes that this specific phenotype is not at increased risk, then the answer, this is a reasonable hypothesis, and this leads to interesting potential conclusions, but it's still a surrogate measure, number one. Number two, that the authors and proponents of this write a very nice story that this high LDL cholesterol phenotype, this lean mass hyperresponder type, is different. This LDL profile is different than what has been shown in the last 50 years. And I don't think there are many causal stories more convincing than LDL cholesterol and atherosclerotic disease. I mean, if you just think about the Bradford Hill criteria, every single aspect of the Bradford Hill causal criteria is there. Strength of association, consistency, specificity, biologic gradient. You know, the higher the lower you cholesterol, the lower the event rates go. So I think it is a reasonable thing to think that having a cholesterol in having LDL cholesterol 300 and 400 is special in this phenotype. But that is a really high bar, and I think to claim that against 50 years of causal evidence requires more than a plausible story and more than 100-patient non-controlled observational study.
If I may respond to that.
Please.
First on point one, I could not agree more in respect to outcomes. The fact is we just don't have those data. So we won't, claim strong outcomes with respect to MACE. Now we could talk about other imaging studies that are quite interesting that have been published in the last year, but that would be a little bit of a tangent. On point two, which I think is more important to clarify, this is one of those areas where I think in the public domain, we lose people. We try not to, but in terms of semantics, everything we've said, I think, is entirely compatible with the idea of a causal role of ApoB and atherosclerosis, because causality does not imply sufficiency, nor does it imply a given variable is per se predictive. So I don't think Dave, Adrian, or I would deny that ApoB is causal per se, but that doesn't necessarily mean it's predictive, that it needs to be lowered in every patient. And with respect to, you brought up a dose-response relationship, that was one of the really interesting findings of this paper. We have, I think, a greater spread than any other study, like a spread of over 400 milligrams per deciliter LDL range, and there was no clear dose response. The interesting part is some of the kickback has been like, oh, well, maybe you've hit like a LDL ceiling, which would counter, and my understanding is it would counter the lipid hard hypothesis, maybe in a stronger way than we're intending to do, the feedback, so to speak. So,
okay, let me hear from Adrian.
It's really along the lines what Nick was mentioning. I mean, this study or these results should not be interpreted as negating the 50 years of evidence Dr. Mandrola has just mentioned on the strong link between ApoB or LDL and major cardiovascular events. I mean, however, I think we have good data to support that this phenotype is different. To put an example, in one of the papers we published already, we searched, we tried to see how many times we could find this lipid phenotype in the entire history of lipid panels in NHANES. And we only found 3 hits in the entire history of lipid panels of NHANES. So I think that it is certainly a different phenotype, because most of the times in all the studies that are, of course, perfectly valid and support the causal link or the causal role of LDL and ApoB in cardiovascular disease, LDL is joined by high triglycerides, low HDL. And that is definitely different in this case. And it's not only a story about why this phenotype is different. There is good physiology and independently collected studies that support that this phenotype is indeed physiologically different. And therefore, even when 10-year studies with cardiovascular events have not been done yet, initial studies like this are necessary to perhaps get to those studies. And of course, they will be limited because this phenotype is still rare in today's world. Most people don't fit in with this phenotype, and those results shouldn't be extrapolated to those patients. But definitely it's a different phenotype. It's a different context.
John, is this phenotype, I mean, this is a phenotype, is the cardiology world embracing that this phenotype is a different phenotype? That's one question. And number two, to Nick's earlier point, it's not a randomized controlled trial. This is almost like a prospective natural history study for folks who have refused statin anyway. So any thoughts on that?
Well, I don't travel in the lipid circles of the cardiology community, but I do read every week, and I don't see an embrace of this specific phenotype. But I will say, Chadi and others, that this carbohydrate restricted diet has tailwind. And for instance, I've gone to carbohydrate restricted, not full keto, and when you do that, you eat more eggs and bacon and protein and saturated fat, and lo and behold, my cholesterol has gone up like 80 point. LDL cholesterol has gone up like 80 points. And so I have a personal connection to this, and I hope that it's different. But I want to also comment, I guess, on the strength of the evidence, right? So, and I don't mean anything personal animus about this. This is a study, and all studies have limitations. But I mean, you have not a very strong level of evidence. You have some data on correlations, but when you really you look under the hood of the non-calcified plaque, that there many of the patients in that figure one, it's going up, and I don't know what it means because I don't give much trust in these surrogate endpoints from images. Number one. Number two, you have it only in 100 patients who are probably highly selected, right? These are highly selected people. Number three, you don't have a control arm. So you don't know what's happening with, say, lean people eating a Mediterranean diet. And so I just think that the strength of the evidence from this study is not enough to make conclusions about whether this phenotype is different.
So, John, just to piggyback on this, I mean, when you see a study like this, you're saying, I can't make any conclusions. Are you suggesting that at least there's a hypothesis that you can draw from where, based on this, you'd like to do a randomized control trial? Like, does it give you a signal that maybe additional studies are warranted, or you just say, okay, this is really not something I'm going to do anything with?
Yes, and I would say that the problem isn't the problem isn't how the data was conducted and what the experiment was. I think the problem, as it is in so many of these observational studies, is in the oversized conclusions. For instance, I just wrote some notes. The authors write, the LMHR population constitutes a unique and important natural experiment evaluating a lipid heart hypothesis. I don't know that that's true. I mean, number one, a natural experiment usually has a control arm, right? They usually have a before and after, or somebody, a fifth grade gets math, sixth grade don't, and there's some comparison. I mean, secondly, our data are consistent with the notion that elevated ApoB, even at extreme levels, does not drive atherosclerosis in a dose-dependent manner. But you can't comment about dose-dependent manner when you're measuring some imaging test in 100 people in a non-controlled experiment. If I did this experiment, I would just say, look, we have this interesting hypothesis. We have this data. It's preliminary. It might be this. We need to do more studies. We need bigger studies. We need a control arm. And I don't think there'll ever be a randomized controlled trial for this because I don't know that it's possible. Maybe in a prison, you could do a randomized controlled trial and follow people for 5 years or 10 years and look at events. But I just think we have stronger data before we make these conclusions. Finally, Chadi and all, if they are wrong about this, and bumping people's cholesterol to 300, 400, and 500. Remember, cardiac events don't happen in a year. We're talking about 4 or 5 years. If a 25 or 30-year-old is doing this, what happens when they're 40? This is how atherosclerosis works. I think the downside risk of being wrong is substantial.
So, Dave, what John is at least, and I want to respond to this, but one of the things he is commenting on, the conclusions are a bit exaggerated. So can you comment on that? And then I believe you had a note as well.
Sure. Well, certainly, I think a lot of what we've got to do is draw into the research, of course, the seminal research of Brown and Goldstein and that of homozygous FH. These
Hmm.
children also did not have control groups, and the population size was substantially smaller. If I'm not mistaken, quite literally, the first it was just two siblings because of how rare this is. It's 1 in 1 million, and if I'm not mistaken, what they published was with four total um, children who were born with it. Not only that, they considered it to be substantial evidence for the lipid hypothesis at that time because the one that they speak to a lot in their lectures is I don't remember exactly what her name is, but as a patient, she had her first stable angina at age 3 and her first MI at age 6. And they say at that point that indeed she had no other risk factors. She wasn't a smoker, she wasn't a type A personality, and so forth. And that it provided the strongest data to suggest that high LDL indeed causes cardiovascular disease. I wouldn't actually be surprised if the last, I don't know, few decades of those studying homozygous FH around the world still actually wouldn't come into the 100 that we have in our population. And we do have some folks that are, I want to say 4 maybe or 5 that have an LDL of 400 or higher, which is typically defined as being homozygous FH, at least before this point in time. There wasn't a way by which somebody would get to those levels. But with that spread, there is an expectation currently by the present day lipid hypothesis, the same one that's described in the 2017 EAS consensus paper, that they're one of those stronger lines and that seem to see the larger, more outsized benefit from lowering LDL, relatively speaking. So I think to be fair, there really is a lot of data that's natural observational that doesn't have a control group. And by the same token, they wouldn't do a randomized control trial with people who have a homozygous FH. They wouldn't randomize some of them to not getting treatment, right? And I think that there's a lot of great data. This is one of the rare times where there's such a huge outsized amount of exposure toward the outcome of interest, given the present day lipid hypothesis. I'll say one more thing that I'm sure my colleagues would agree with, which is there's really kind of two variations of the lipid hypothesis. There's the one which we kind of know today, which is expected to be universal. It's expected to be that the reason for the high LDL, high ApoB is not that relevant because it is independently causal. And then I think that there are a lot of people who do think that there is more to the story, especially if they're looking at more recent studies that show there is a heterogeneity, even among those who have monogenetic FH. So I do think that there's room to look at our data and to consider that in this larger umbrella.
Adrian, you had a comment?
Sure. I think Dave and Nick and everybody else in the authors list would agree that we don't perceive this study as a definitive study, as the end of a conversation. If anything, is trying to suggest that more observations, even when I agree it's unlikely we will ever have a 20-year-long randomized controlled trial with this phenotype and major adverse cardiovascular events, I think it's the start or the initial argument for more research on this phenotype. And also, I think they would agree, we don't think these results or conclusions say anything about people beyond this phenotype. Most of my patients don't look like the inclusion criteria of this study. Most of my patients, even when they are lean and we observe the cholesterol changes we've studied and published about, many of them start a ketogenic diet after years and years and years of poor metabolic health, already have lots of plaque. And I would say that most of my patients, even those with an LMHR phenotype, are on a statin. So I don't think it's not, I mean, we're not trying to say
Right.
the entire cardiological field needs to change its guidelines. It's just that these observations perhaps warrant more observations.
John, if you see Nick's cholesterol is close to 600.
Can I jump in, Chatty, and just add one more thing?
Sure.
In response? Thanks. Sorry. I want to double click on the idea of whether or not lean mass hyperresponders are a unique phenotype. And I come down on the hard line of like, absolutely yes. And I think you can define that by even single patient cases. I've tried to do kind of dramatic things in myself to make that point. Now they're going to seem extreme, even clickbaity, but I do it to make the point that this phenotype deserves more study. So, I don't know if you know about my Oreo versus statin experiment, but one experiment I did with Professor William Cromwell, I'm not sure if you know him, but I did a crossover trial on myself where I used Oreo cookie supplementation versus 20 mgs of Crestor. And the Oreo cookies were actually more effective at lowering my cholesterol. Now, that was a prediction I made a priori. It's an N equals one. So if we're talking levels of evidence, that's even, say far worse than this study. Nevertheless, I think anybody would agree, like, if it's something that can be predicted a priori and works, then there's something going on here that's weird and that's different. The reason I do something like that is because I feel the frustration of people who have the LMHR phenotype. Now there's a Facebook group, Dave, with what, like 13,000 people who feel, I'm just going to talk from, again, the patient experience, that the cardiology and lipidology community is sticking their head in the sand with respect to this phenotype. So it's true. This study does not constitute the highest level of evidence. But the reason for that is because Dave went around for years trying to get people interested in this, and they kind of turned their heads. So we had to crowdfund a $250,000 study to force a conversation. As Adrian's put it, we're not trying to end a conversation, we're trying to start one. So what we want is collaboration. What we want is more resources to do more rigorous studies, but we needed to get a starting point. It was this.
John, if you see Nick in clinic and he comes to you for a consultation, his LDL is close to 600, would you, obviously you can't force him to take a statin, would you, and you have now the study results here, would you recommend a statin or no?
I would because I would just lean on 50 years of evidence. And I'm sensitive to the fact that this could be a true story. This could be. We were wrong about a lot of things in cardiology, and I came through that. I like to write about all the things that we were wrong about. We were wrong about big things, and we could be wrong about this. There could be a special phenotype that is consistent with this story. But I don't have that I don't have that level of belief from this. I mean, if you just think of it from a Bayesian standpoint, you have a prior belief. You have 50 years of evidence about how LDL relates to atherosclerosis. And as far as the familial hyperlipidemia story goes, hypercholesterolemia. It's not just a couple kids or couple families. It's also effect size. You have a huge effect size, and we're not talking about changes in CT scans. You're talking about cardiac events at young ages. So I think that data is very, very strong. Okay. Then if you have a Bayesian view where you have this very pessimistic belief that one group of people are different, you need a strong likelihood ratio to change that prior belief. And this study is a study. It's reasonable. People worked on it. There's data, but it's very far from changing a hugely pessimistic view to a potential view. And I would also push back on the authors with all kindness and generosity that this was not. These were strong conclusions. These, quote, these insights can facilitate personalized treatment risk mitigation strategies based on modern, cost-effective cardiac imaging. I don't think a 100-patient study, uncontrolled study can say that. I mean, I think what I would have said if I had done this study or been an author on a study, I would have said, here's our data. They're interesting findings. They warrant more study. This group may be special, and that's all you say.
So John, I have a question here though, because I did do a lot of peer reviews until I literally ran out of time, and I honestly, unfortunately, declined a lot of peer-reviewed papers. But if I were a peer reviewer, I would have asked the authors in my comments as a reviewer, one or two, can you tone down the conclusions? Why do you think the peer reviewers did not ask for that? Just any thoughts?
I'm not sure. When I do peer review, Chadi, it's about all I can It's about all I can add to a paper. I can only add context and clinical context. I can't really criticize the statistics. I can't criticize a lot of the prior hypotheses, but I can say that we have been wrong a lot, and we have been led astray by observational data. And I would have just asked for a more gentle conclusions and more humble conclusions.
Before I ask Adrian to comment, he's graciously has his hand raised. I want to just step back a little bit just for listeners. When we talk about the calcium score, the CTAs, all of this thing, can you give us like a quick 60 seconds? I mean, you say it's a surrogate. It doesn't really correlate. It is getting ordered a lot and so on. Do you think like what are the indications to do a CTA, calcium score?
Are you asking me?
Yeah. Like when would you order that? Like
okay, yes, I can. A coronary calcium score measures the coronary calcium in the coronary artery. It's a very, kind of screening test where you get a number. It could be 0, no calcium. It could be 1,000, a lot of calcium. Calcium develops over years. The calcium score proponents say that it can help people who are intermediate risk decide on whether or not to take a statin. So let's say you're 45 years old and your 10-year risk of cardiac event calculates via the pooled cohort equation to like, I don't know, 6%. And if you get a CAC score and it's high, that might go up to 8 or 9%. And then you'd be like over that range where experts would say you'd benefit being on a statin. Vice versa, if you're in the 7 to 8% 10-year risk and the calcium score comes back 0, CAC proponents would say, well, that gives you a lower risk and now you're good. You don't have atherosclerosis. Andrew Foy and I have written that is we don't see any role of CAC scanning because we don't think any normal person can contextualize a 7.5 versus 6.5 versus a 10% 10-year risk. I mean, my 10-year risk calculates at 10%. What's the difference between that and 7.5% or 12%? I can't contextualize that. Number two, in the real world, it leads to a lot of downstream testing. Someone gets a high calcium score, they get scared, they get a stress test, a cardiac cath, and invariably a stent that is of no benefit to them in terms of reduction of events. And number three, what I worry about, I think as much as any, is when you get a calcium score of 0 and you have a high cardiovascular risk, that the proponents say that lowers your risk, but they're using observational data to affect randomized controlled data on statins. Statins are the #1 most studied drug in medicine. 100,000 or more patients have been studied, and the statin effect is consistent. It's a 25% risk reduction, no matter what your 10-year risk is. And so when somebody has a high 10-year risk, and the CAS score comes back 0, proponents say, don't worry, you don't need to take a statin. But that's observational data going against randomized control data. Chadi, this study, though, used both CAC and CTA imaging. And I think that the both of those images, both of those baseline criteria seem to correlate with plaque progression. And so I don't know if their imaging test in a 1-year study. So again, I think it's limited, but that's the story on CAC.
Yeah. Adrian?
I wanted to emphasize or perhaps clarify what we mean with this could be useful for personalized data. Point I frequently make is that in medicine and in many other things, when we think we found an answer, we stop looking for other possible explanations. And if there is one additional point I think these results are useful for, is that for these participants, if they show up to their doctor and let's say they have multiple cardiac imaging, they fortunately haven't had a major adverse cardiovascular event, but they have multiple cardiac scans and it shows progression. The first suspect is going to be their LDL. And this data suggests that clinicians should look beyond their lipid panel, because I'm sure Dr. Mandrola will agree there are risk factors beyond the lipid panel. So I think that this is important. This is useful to personalize advice. First of all, because it reinforces the message for people with this phenotype. You can get predictive information if you go and get a scan of yourself, but also because it shows or it supports the idea of being mindful of other things. We are working in these data sets right now, and this should remind people and should remind clinicians mostly that, okay, maybe, don't be falsely reassured because you lowered cholesterol that their cardiovascular risk went down. Perhaps there's still inflammation creeping back. Perhaps there is uncontrolled blood pressure. Perhaps they are developing insulin resistance. Perhaps there's other things beyond the lipid panel that are raising these patients' cardiovascular risk, and that perhaps you don't pay as much attention if you think you already solved cardiovascular, or you're already improving cardiovascular risk because you prescribed a lipid lowering drug. So that's what we meant with personalizing advice.
Nick, I think you had one comment. I'm going to go back to John, but did you have a comment?
Yeah, it just has to do with observational research and CACs. There's some. I'm curious as to what you think of the data. Say, like it was, I think, Mortensen's paper in Circulation in 2023, and those like it. But they look at large populations of people and follow them for, in I think the one case, the Western Denmark heart study, it was 4.3 years. And the people with a CAC of 0, there's no association between LDL and heart outcomes like MI, and then replicated in other cohorts over a longer time frame, including, I think, the MESA cohort, it was replicated at 16.6 years. So people with CAC, no increased risk with higher LDL, even when you partition at LDL above 193 versus 116. Now, I realize it's observational, but I think they're interesting data. And I also think it's a little bit unfair to just pit RCT versus observational and say the former is better when we're in a scenario where there's certain studies we just can't do randomized control trials on, like the scenario we have here. So there's like levels of evidence we'll never be able to collect. So to just say RCTs trump them, I'm not sure I can get on board with that. In addition, I get the idea of 50 years of evidence has weight and the preponderance of evidence has weight. But I would also say the preponderance of evidence weight should be weighted according to how well the population in question matches the populations from which the preponderance of evidence was drawn. And in this case, we have a population unlike any population before. So I do not discard 50 years of evidence, but I do caveat it.
John?
It's true. It's true. You're talking about external validity. It's one of the most important critical appraisal aspects is, do people in the clinical trials and represent people? And it's true that this ketogenic diet, this carbohydrate restricted diet, is probably a modern phenomenon. And it may be different. I hold out some probability that these things are different. As for the observational data and randomized controlled trial data, I also think the CAC 0 probably portends a lower prognosis, a better prognosis. It probably does lower 10-year risk. However, you have to think of the statin evidence as one of the strongest pieces of evidence in medicine, that in every population except for end-stage renal disease and the sickest of patients, statins reduce risk of non-fatal events by 25%. If your risk is 3%, you go down to 1.8%. If your risk is 20%, you go down to 15%. The relative risk reduction is consistent in whether you have heart disease or not. Now, you can argue about the effect size, and some people would say it doesn't change mortality. It's a small risk reduction, but it is a risk reduction. So what I worry about is just using observational data to say, don't worry, you don't need a statin because your CAC is 0. What's more, I can also cite observational studies that show that if you're an older adult, a CAC 0 is far more predictive than if you're a younger adult. If you're a younger adult, the CAC 0 is less reassuring because you haven't had time to develop coronary calcification. So again,
But John, what I think the question is, this lower reduction of 25%, does it apply to this particular people who are the hyper responders? Because these prior studies may have not included this particular patient population. And I caveat that by just saying, I'm an oncologist. I actually don't think it's very difficult to do randomized controlled trials in rare patient populations. Like, if you have adrenal cancers or certain things that you have the number of people, but this may be different here, right, John? I mean, John, you can comment.
well, I would say, Jody, I would say that it's a reasonable idea that this phenotype may be different. In other words, because of their triad, because of their lean body mass, the absence of cardiometabolic risk factors, that they may have such a low event rate that the statins don't apply to them. But the thing of it is you have to go by probability, and you have to go by, if there's hoofbeats, it's a horse, not a zebra. So again, there have been more than 100,000 patients studied in statin trials. Younger people, older people, post-MI people, pre-MI people. And every single study shows the same thing, and it's also on a grade. And so if you're going to propose that this group is different, and that you don't have to treat a statin of or LDL cholesterol of 300 or 400, then you have to have stronger data than this study.
I have to respond to the hoofbeats.
Yeah, but Adrian raised his hand first. But okay, Nick, you go first. Okay, Nick.
Well, all I wanted to say is I've been a zebra my entire life. Every time I've gone to the doctor's office with a complaint, that heuristic is applied and has generally been wrong. And what we're talking about here is a population of zebras.
Okay, is that a population of zebras, John?
Oh, Nick, I'm sensitive to that. I am sensitive to that because doctors don't, in general, you made a generalization, I'll make a generalization. In general, doctors are not very humble. And I've been doing it for 30 years, so I've developed a fair amount of humility. But if we're going to be evidence-based practitioners, if we're going to be neutral judges and evidence-based practitioners, we also have to go with what the strongest data is. And look, I wouldn't have a contentious discussion with you about statins. I'd be like, in my view of the drugs, they should be over the counter. They should be over the counter. You have a statin aisle and you have a little calculator and you calculate your risk reduction, and it's up to you to decide. Now, people don't want to do that because statin use would probably go down, but that's how I view it. And I don't know, but I need better data than this to change my view of the strength of the data.
Adrian and then Dave. Adrian.
I would like to say, and that my prediction, and I know at least some of my co-authors would agree, is that if anything, this study is going to increase the amount of patients with an LMHR phenotype that now accept a statin, precisely because of the results they get from cardiac imaging. We know from other studies, for example, that after above a CAC of 300, people behave more like secondary prevention or get the number necessary to treat of secondary prevention, like primary, than as someone who already had a heart attack. So many of my patients arrive to my office, their CAC is 450. Well, forget about it. You get a statin. I know some cases, some of the largest reductions are seen in people with CAC, but I totally agree here with Dr. Mandrola. I mean, if I see a patient with a high CAC, I advise for a statin. And this study, if anything, has made more people with an LMHR phenotype aware of the importance of baseline plaque. And my prediction is that it's going to actually increase the amount of people with this phenotype that accept a statin. The second thing I wanted to say is that I love that Dr. Mandrola is probability based, and he already mentioned Bayes. I also consider myself a Bayesian, and I would say that the Bayes factors we put in table 3 are very, very, very strong, and they resisted having less than half of the sample size. And I'm not saying they are enough. I totally agree. More, better data is needed. But I would say that, being a Bayesian should at least update our prior belief towards the null, because they definitely are more supportive of the null. I'm not saying they are confirming the null, but they should at least update our priors towards the
Got
null and not towards the
it.
alternative.
Dave?
As far as I know, all studies that are interventional, particularly if they're treating cholesterol, they are focusing on populations that either partially or exclusively include folks that have something such as metabolic syndrome, such as homozygous FH, for which the nature of the disease I'm describing both changes the lipid profile and is an independent risk factor for cardiovascular disease on its own. Usually treatment that applies better the further you are toward that independent risk factor. It's very important for when we're trying to evaluate the data on how much LDL and ApoB independently causes atherosclerosis. Because without this by definition confounder that's affecting both, it's very difficult for us to be able to disentangle the two. And this is a challenge with trying to figure out low-risk populations post hoc, actually doing like subgroup analysis after the fact. It's why we've needed to do a prospective study on a population that has neither of those, that does not have something that affects both the lipid profile and also affects the outcome of cardiovascular disease independently. That's why I don't think we can yet make that claim without being able to get greater and greater data for people that are metabolically healthy and do not have either of these. It's why I think it's not even just lean mass hyperresponders that I'd like to see more data on. I'd just like to see more interventional data on metabolically healthy populations without cardiovascular disease risk factors in general.
John?
Yes, but until there is data, strong data showing that this is special, I think the downside risk is substantial to change your view of this. It's a great hypothesis. It's a nice hypothesis, and I think it deserves more study. If there's 13,000 people in a Facebook group who are on carbohydrate restricted data, there ought to be ways to do prospective longitudinal studies to look at this. But a 1-year imaging study is not anywhere close to enough to potentially withhold heart disease reducing therapies, because you think this group is special, and it may be. I'm not saying it's not, but I'm saying that you have a theory and you have potential risk of not treating a cholesterol of 300 at age 25 or 30.
John, is there enough signal in the study to justify a next step of a randomized controlled trial? Because next I'm going to ask Adrian whether this is planned.
I don't think you can do a randomized controlled trial of anything nutritional. It's so difficult, right? I mean, I'm not sure how you would do it, but I think you could do better observational or more observational research. I mean, much of the LDL theory began before statin therapy and interventional trials. I mean, tell me what happens to these 13,000 people with carbohydrate restricted diets. Just something as simple as just comparing their event rates to historical controls. I mean, just something. And this is a modern phenomenon, right? The ketogenic diet is modern. We don't have a lot of historical data on it. So I'm curious, I'm interested, but we don't have it. And this is not enough. This is not enough to say we should be doing imaging. This is not enough to say we should be thinking these patients are special. We should be scared that a 25 or 30-year-old has an LDL cholesterol over 300. That should be scary because we have 50 years of data. And it might be different, but this is not enough.
Adrian?
I would like to emphasize that it's 1-year imaging, but I mean, we have evidence on these people being on the diet for half a decade, and that their lipids were normal before they started the diet. So I think that, I mean, the exposure time is not 1 year, it's longer than that. However, I agree that this is, I mean, that better and more data is needed. I totally agree with that. And I just wanted to emphasize that this is almost half a decade of exposure.
Right.
And perhaps I would like to, I mean, all things equal, with the inclusion criteria and the baseline characteristics in table 1, what would be your estimation, Dr. Mandrola, that what percentage of participants with these LDL levels and these baseline characteristics should we see have a major adverse cardiovascular event in the next 5 years? Because for the first 5 years, we haven't seen them. How many should we see in the next 5? What would be your estimation?
I mean, you have historical controls. I have no idea. I don't. But when a non-smoker has an MI, my interventional partners often call me to let me know because it's so uncommon when a 50 or 60-year-old has an MI who's a non-smoker. And so I'm not worried what happens in 2 years, 3 years, and 5 years. That doesn't bother me. The point of primary prevention therapies is to get people to age 70 and 80. So we give primary prevention, blood pressure medicines, statins, lifestyle advice to 30 and 40 and 50-year-olds so they become 80. I mean, that's the problem with atherosclerosis. It's so slow and progressive. You don't know. And I think you need longer longitudinal studies than 5 years because a 25-year-old, a 25 or 30-year-old, they're bulletproof. I mean, they can do anything to them and nothing's going to happen to them at age 30. Same thing at 30-year-old. Nothing's going to happen at 35. What I'm worried about what happens at 45. If a non-smoker with a cholesterol of LDL cholesterol over 300, if they start having heart attacks at 45 to 50 to 55, that is a public health disaster because non-smokers shouldn't be having MIs at age 50. And you don't know that.
Yeah, Nick, what is the next step here? Like for you guys, I mean, you've done this, it's published and so on. Obviously, the purpose, I brought John here and you guys here because there's been a lot of social media and a lot of criticism. But are you doing anything next?
Yes. The answer is yes. I'm going to take the scenic route to get to the definition of the yes. But I think one thing we've been beating around is the idea of quality of evidence and is this a unique population? I want to double down on the fact that this is a unique population. In fact, we have randomized controlled trial level data to suggest weird things are going on here. Adrian spearheaded a meta-analysis of the 41 human randomized controlled trials on low-carb diets, and we found a dose-response relationship whereby leaner people have higher LDLs when they go low-carb, a larger jump in LDL, and it was a much more predictive factor than saturated fat by about 5-fold. So there are interesting things going on here. Now that's mechanistic, which is distinct from saying unique with respect to risk. But something else I want to emphasize is Dr. Mandrola correctly said, getting this wrong it could be catastrophic. Like it is very high risk. But I'd also contend is that it's irresponsible and high risk not to study this population. So if we take that this is a unique group of people that deserves further study, it's been around in the zeitgeist. Dave has been waving the flag about it for the better part of a decade. Then why are we the only ones studying it? And maybe it's not in the most rigorous manner, but it's like what we can get done, what we can get started. So I give Dave tremendous credit for that and pursuing that. Now, to answer your question, Shadi, this is the beginning of the conversation. This is the first study that has actually been, the nucleus, the beginning of a snowball to allow us to acquire more resources to do more studies. I'm going to pass it to Dave to speak specifically about the next study we have in the pipeline. But I will say behind the scenes, as we require more resources, there are a ton of studies, both mechanistic and with respect to risk, that I'd like to do.
Yeah,
but Dave,
and I have to say, I mean, Dave, you'll tell us what our next steps, but I do want to, I mean, as a neutral, I want to applaud the fact that you are doing more studies. You're not saying we're done. I do think you deserve credit for this because you're not saying we're done. John, would you agree that this is at least that additional investigation is warranted or something?
Yes, far more. But I tell you, Chadi, if this transcript of this podcast was sort of chat GPT'd into the discussion, there'd have been almost no social media debate, right? It's really the outsized conclusions that that flew too close to the sun.
Dave, next paper, please tone down your conclusion, but go ahead, Dave.
Yeah. Well, let me ask this of you, John. Even if we were not in this space at all, even if there was no Dave Feldman, I'll bet you would agree, because I know it's gone back as far back as the lipid hypothesis. There have been many people who have not had any interest in taking statins or lowering their cholesterol, have made documentaries like Statin Nation and things like that, right? So there's always been a lot of non-adherence this whole time. I think it's all the more reason why it's great to have an effort towards looking at a population that may themselves believe that they are not at risk and find out, with it's the same conclusions that we would be coming to in that these studies are not done by people like me. We know we're out there even before I'd come into this space, even before I knew much about cholesterol. I know cardiologists have been facing this the whole time because now many of them are my friends and I know
So
what they did.
what are the next step, Dave? And then I want to take last comments from everyone because I think and Adrian, I know he has his hand raised, but next
Yeah.
steps, Dave. What are you guys
So
doing?
next steps, we've been raising money. And by the way, I have to count my two colleagues on here for helping out. We've been raising money, including with the conference COSI, toward what's codenamed the Triad Study. And the Triad Study will have a control group. It will be a modestly more relaxed criteria, and we're still in the process of figuring out its design. But to exactly what you said, Chatty, its intent is for us to have yet one more study, as opposed to having just the single study that we have currently.
Adrian, you had one comment, then I want to go around and get last final thoughts.
Sure. I think that being absolutely honest and transparent, I mean, this paper did give us lessons on communication. And some people have focused more on the title, some people have focused more on figure one or the discussion or on the conclusions. I would like to say on our behalf that our actual conclusion section is very descriptive. It's saying simply over 1 year, this was associated, this wasn't, and then that's it. Perhaps a better title was, or a more accurate title could have been better. Sure, we already acknowledged that in the letters to the editor. Perhaps including a numerical value of primary endpoint would have been clearer, besides every single line in figure one. Sure. I mean, I think that research, fortunately, because otherwise I would be jobless, is not a static thing. And more research, we are working already on understanding what tells apart the fast progressors from those who were not fast progressors. I mean, we're already working on characterizing the ones from the others, because we already have some data to do that beyond, cardiac imaging data and lipid panel data. We also have inflammation markers. We also have more advanced lipid metrics. We also have other biochemical data. So I think that's certainly in the pipeline. And sure, I mean, we are not saying this study was perfect, this is the last study, and that everything should change after April 7. And this doesn't mean we didn't learn anything. Sure, I mean, communication. I don't have a single paper I cannot go back and say, oh, I wish I would have done something different. So I think that's also true. And yeah, more is to come.
Nick, last thoughts.
Dr. Mandrola is dead right that to get this wrong and not to have data is dangerous. So I guess my call to action is let's get those data. And we're trying to. As Adrian said, we can always do a better job on communication. I think one of the really interesting things, I'll just say generally about my young adulthood, setting aside just science, is the degree to which intent and perception can be mismatched. Be that in writing a paper, or be that in talking to your girlfriend and she gets angry at you and you're like, what just happened? But in all those situations, I think it's worth reflecting on the, part you had in it and how you could do better next time. And I know all of us are considering that, and we appreciate you taking the time to give your candid feedback. I really enjoyed this discussion.
Great. Dave, any last thoughts? And then we'll finish with John.
No, I was about to say the same thing. And in fact, I really wanted to thank you, John, for joining us and sharing your thoughts. It's been incumbent on me, and something I've really appreciated, for whenever we've been able to have a productive discussion with our research. I think all research should be open to respectful challenge. And I thought that this was a great example of this podcast itself. And I really appreciate your input greatly. So thank you once again for joining us.
John, take it home.
Number one, I learned a lot reading this paper. I actually didn't know much about this lean mass hyperresponder phenotype. So I think my knowledge base has been increased. It's a very curious hypothesis, but I would just caution all listeners that are interested in critical appraisal is that the history of medicine is replete with examples where bioplausibility and mechanistic studies, mechanistic theories were just outdone by clinical endpoints. And I think you just have to think of imaging as a surrogate endpoint. It may or may not be right. The ultimate conclusion will come with clinical events. Cardiology and is about clinical events. It's not about changing images. It's not about changing lab values. It's about reducing endpoints and living longer and living better.
Folks, thank you so much. Really, I've enjoyed this. This was really great, and I appreciate you coming on. This will be aired soon, and I really appreciate your time. Thank you.
Thank you. And also thank
you.
you, Dr. Mandrola.